Hello, good afternoon, good evening, everyone. Thank you for being here for this symposium. I know it's a bit late in the day, but I promise you that you have an exciting time. So today we're going to be learning about how the private sector is getting involved in malaria program elimination in Nigeria. My name is Perpetual Homoibi. I'm the Nigeria Program Manager, National Malaria Elimination Program. And the symposium, the topic of the symposium is the road to malaria elimination using community health structures with private sector support in Bonny Island, Nigeria. Bonny Island is in Rivers State, southern part of the country, and the Nigeria Liquefied Natural Gas Limited is operating in that Bonny Island, and they've taken it upon themselves to support their host community, their operating environment towards achieving malaria elimination. So the speakers here today will be Charles Epelle. He's the Manager, Community Relations and Sustainable Development, and he will be speaking on introduction and objectives of the malaria elimination project in Bonny Island. The next speaker is Dr. Okuns Ohiosimuan, who is the Manager, Corporate Medical Services at the Nigeria Liquefied Natural Gas Limited, and he'll be talking on how it all started. The third speaker will be Edima Ottoho, who is a doctoral student at Boston University, and she was formerly on the project. And her topic will be the use of behavioral economic in health facilities and communities to drive ownership. And the last speaker, but not the least, is Dr. Anastasia Isodje, the technical manager, Bonny Malaria Elimination Project. And her topic will be reaching every household through strong community health systems and local structures. Without wasting much time, I'll hand you over to the speakers. Thank you.
Good evening, everyone, and welcome to this session being sponsored by Nigeria NLNG Limited. Before I go on, I would just like to crave your indulgence to allow me to give you a brief introduction of Bonny Island and also the company Nigeria NLNG Limited. Nigeria NLNG Limited is situated on Bonny Island, and Bonny Island is an island in the Niger Delta area of Nigeria at the southernmost part of the country. It is surrounded on the southern part by the Atlantic Ocean and on the northern part by the swamps. So it's surrounded fully by water. The island is a kingdom on its own, being ruled over by a king. And so it has a very strong and influential community structure. And it is that structure that Nigeria NLNG Limited leverages on to execute the malaria elimination program. Besides that, it is also a local government area of its own. And it has about a population of over 300,000 persons. And if you begin to consider the effect of malaria on this small community with respect to economic development, you will understand the reason why the company Nigeria NLNG Limited considers it a credible corporate social responsibility to partner with other stakeholders to ensure that malaria is properly managed to the point of elimination if the work we're doing gets to that point. And I hope you now understand where we're coming from and why the company is into this. Sorry about that. Okay, let me go back to the first slide. As you can see, over there is the liquefaction plant of Nigeria LNG. There are 6 of these plants producing over 22 million tons of liquefied natural gas. And the natural gas is shipped to various countries around the world for energy purposes. And this is the satellite map of Bonny Island. As you can see, over down here is the Atlantic Ocean, and these are the swamps. And if you move that map further up, you will see that this is the southernmost part of the Niger Delta. And if there's anyone here who has not heard about the Niger Delta, I think you need to do some additional work to understand the Niger Delta of Nigeria and its contribution to the economy of Nigeria. Before I go on, I would just like to further let you understand that the gateway to Nigeria's economy is through Bonny Island, one of it really. And Bonny Island has played a very significant role in the advancement and development of Nigeria's economy right from the times of the 16th, 17th, 18th, 19th century and going forward. It's the estuary through which cargo, both maritime and otherwise, get through and out of Nigeria. And so it's a very significant island, and the kings of this island have been recognized by the imperial majesties of the United Kingdom. At a point in time, Bonny was recognized as a state, and it had the United Kingdom's consulate set up in the community. And just a little bit more, the very first lighthouse and telephone cable in Nigeria was installed on Bonny Island. So it's a very significant island for us not to recognize its significance. So after this, I'm just going to go into the introduction of what we have now. The issue of malaria elimination in Nigeria, most especially in Bonny Island, is something that we want to talk about here. And like you all know, malaria is presently recognized as one of the world's deadliest mosquito-borne diseases. In the year 2000, malaria itself was identified as the #1 major impediment to global development and was also selected as a critical target of the Millennium Development Goals. And that leveraged into what we have today as the health section in the Sustainable Development Goal. Even though malaria is still recognized as a public health concern to the global community, it contributes a lot to the major economic losses in some poor countries and most poor countries. From all indications and from the data we have, Nigeria accounts for about 32% of the global malaria burden, and this affects productivity and economic development, as you can see from the map of Bonny that I showed you, with just about 300,000 persons. If you even look at the percentage of prevalence in the community at about average of 5%, 5% of 300,000 is a whole lot of people. Of course, in semi-urban communities, they have high percentage of the population in this category of poverty. And of course, the private sector is the economic hub of most nations, and therefore remains an untapped resource for health development as we speak, and so to speak. Now, I've talked a lot about Bonny Island, but let's see the background of how we got here. The company, Nigeria LNG Limited, is on Bonny Island. And like I've explained before, if you look at this, this is the map of Nigeria. And like I said, the southernmost part of the country is where Bonny Island is located. And as you can imagine, going into Bonny Island is only by sea or by air. And there's only one airstrip on that Bonny Island, which does not take aircrafts that are bigger than what we call the Dash 8 or the Donia 238, maximum of 30 passengers. at a point. And the community is looking towards a situation where the island will become a tourist destination. And if you want to go to somewhere to spend a week or two and you come back with malaria, then you will never want to go to that place. So what we have doing is that as part of the corporate social responsibility of the company decided to go into several health initiatives. We have what we call the Ibanise HIV/AIDS initiative, which was an initiative that was put in place by a company to tackle the prevalence of HIV/AIDS in Bonny Island. At a point in time, Bonny Island, as you see it, had the highest HIV/AIDS prevalence rate. But with this initiative, it actually has one of the lowest today, if not completely wiped out. And then, as part of it again, the company went into what we call the Community Health Insurance Program. And the Community Health Insurance Program was designed, or is designed, to ensure that the poor people in the community receive health insurance that could enable them access health services at a very cheap rate. 10,000 naira in our own country, 10,000 naira is just about $22.2. And that's how much an individual or a resident in the community is expected to pay for insurance cover for a period of 1 year. So these are some of the things that are happening. But when you look at it again, more than 70% of the cases that are seen in the health facilities are from malaria. And so if you want to invest in health insurance, it makes more sense and good business sense if you fight malaria, so that people will be rather be provided services for other illness and not just malaria. So that became how the Bonny Malaria Elimination Project came into being. And we also wanted to remind the symposium that COVID-19 pandemic is one of those things that would have reminded us of all the connectivities that we have as individuals and in households, Bonny Island as well. As a company, we really want to future-proof, we call it future-proof our company by ensuring that even those who work with us, including myself, are protected from malaria incidents. Now, as part of our introduction, don't forget my own bit is introductions and objectives. As you can see in the photographs, you see when we started the journey towards malaria elimination. The fact is that at a point in time, we had to sign an MOU with the United States PMI, which is one of the agents, in fact, the agency that is contributing technical support and guidance to the Malaria Elimination Project team. I can begin to describe these photographs for you, but I don't know if it will be of any interest. But just to indulge you, sorry. This was when we were doing our baseline survey. Just look at the background and see these are thatch houses for the community people. And so you begin to understand when we talk about poverty. This here was when we had the induction of the Operations Management Committee. There were 3 functional groups in that. As you can see, some of them are actually from the community themselves, taking ownership. And here, as you can see, was when we were distributing and surveying with the United States PMI in collaboration during some of our surveys. Here you see the visit of some PMI technical team to the community itself. See the background again, thatch houses. And this is where people will not even be able to afford medicine, a minimum medicine for malaria treatment. And here also is when the executive management of Nigeria NLNG Limited had a session with the US PMI when they visited Bonny Island recently. And let's not talk about COVID-19, but on how it disrupted what we started in 2019. This here was capacity building in the government health facility. And here is a picture of when the MOU, Memorandum of Understanding, was signed with the United States PMI, and handover of malaria commodities to the government of Rivers State and the project team for malaria elimination. And take a look again at this background. If you are a researcher or someone who is into malaria elimination program and you come in contact with some of these, you will understand why the company decided that this should be a CSRO in partnership with agencies. Now, I think I've spoken a lot, but let's just say that the objectives of this symposium was to create, present the partnership that we have had and the model that is working to bridge the funding gaps for disease program management, not only in Africa, but on Bonny Island, really. It's also to discuss the behavioral economics and modifications of provider behavior for improved malaria case management on Bonny Island as well, and for us to discuss the community health system strengthening strategy being used for the malaria elimination project on Bonny Island. The presentations, like the National Coordinator for Malaria Elimination has stated, my next speaker will handle how it all started, even though I've given a little bit of it. There will be a presentation on the behavioral economics in health facilities and communities, and we'll end with reaching every household through strong community health systems and indigenous people structures. This is where I'll go back and sit down while I wait for my colleagues to finalize the presentation. Thank you.
Thank you, Charles. Good evening, everybody. Charles has actually made my own part of the job fairly easy. And I'll just be elaborating a bit more on how it all started. And we did get a lot of questions. I hope you all passed through our exhibition stand 130. One of the questions we kept getting was, what's a liquefied gas company, LNG, doing in the space for malaria? You've heard a bit of it. So basically, I'm not going to go through the stats, which you probably all know better than me, but I'll tell you what struck us when we were looking at the Bonny Comprehensive Healthcare Insurance Scheme. The preliminary reports that came from the body that went to assess the health facilities suggested that 70% of all outpatient cases was malaria. And we said to ourselves, okay, 70% of cases being malaria. But we already knew, based on a lot of research some of the people here have done, is that there are a lot of challenges with making a diagnosis of malaria back home, problems with both under and over diagnosis, problems of treatment without testing, poor access to health facilities, etc. But the question was, so really, if we indeed have malaria to this level, which we should therefore confirm, would we not be wasting a lot of our insurance funds if we're going to spend something close to even 50% of it simply managing malaria, and what could be the morbidity mortality on the island? So when the executive management saw the data, they said, okay, look, why shouldn't we be talking about malaria? It's an island. There have been islands that have eliminated malaria. So why shouldn't we be talking about? And that was really the birth of it all. So basically, three things we felt we had to do at the beginning: health systems assessment to see what was on ground. We had to do kind of like a mini survey. I think Anna will talk a bit about it, and actually some mapping for advocacy, communication, and social mobilization. So what did we find? With regards to the health system assessment, what we did was we adopted the USAID Health Systems Assessment Manual version 2.0, modified it a bit. We did an indicator survey, basically a cross-sectional study, which we drilled down to the households, taking advantage of the very well-structured system they have on the island. It involved about 146 interviews with PPMVs and also 21 birth attendants. And we found out that a lot of the management of malaria was actually not in the formal sector. More than 50% of the malaria management is not in the formal sector. So therefore, these were very key people who both do the, in quote, diagnosis and treatment of malaria. 71 focus group discussions and 15 key informants. Yeah, okay, a bit small. But so what did we find in the health systems? What we found was that the structures were monthly funded by the government. They had staff, enthusiastic staff. There was some utilization of the health facilities, but there were a lot of opportunities that we found. Opportunities around the fact that even though the country has the National Malaria Elimination Program, very well structured, 7 excellent thematic areas, even though there was some knowledge about it, implementation was very poor. Record keeping was very poor. When you went to the laboratories, even though RDTs are available to some extent, they seem to prefer microscopies, yet there seemed to be an assessment that were done by some experts that microscopy perhaps was not being done very properly. So we recognized that there were opportunities for us to improve certain things on the island in terms of malaria treatment and diagnosis. We looked at, out of the 5 private hospitals on the island, I think we also assessed 3, so we got a fairly good idea of that. The baseline study showed us that the average slight prevalence for the island was 5.4. A bit lower than I thought it would be, but when you drill down, it was somewhere between 0.7 to up to 12.5% in the 6 of the wards we looked at. When you then looked at the, if you look at the map bottom left, where we looked at settlements, what was significant was that there were certain settlements that were hotspots, and we knew therefore that would be an opportunity for us to make an impact there. There was a particular settlement that had a prevalence of just over 32%. Over 32%. And like you saw in the picture that Charles showed us, a lot of these places were not even places where you can think of IRS because of this infrastructure and the kind of places where they live. A lot of them even living outside, outside of the huts. We looked at wealth quintiles, and we tried to relate that to malaria. Not surprisingly, it appeared the poorer the community, the higher the incidence of malaria that we found in those places. For the ACSM mapping and profiling, this was carried out to help us identify basically our influencing audiences. That's going to be an entire presentation that is going to be given, so I'm not going to talk too much about that. I think one of the real big things that came out will be the last presentation you will hear, which was the presentation, which is about the operational management committee that was set up. And this was really very instrumental in a lot of the things we did in the net distribution that was done early this year. I can tell you that we mapped of all the households on the island in the 6 wards, within the first 1 week, over 90% of them had gotten their nets. And by the end of 35 days, I think 97% of them had gotten their nets. And these were PBO-based nets based on the initial entomological studies that were done. So we really are looking forward to seeing what impact that will have as time goes on. All right, so let me just share with you very briefly vision and our targets. Basically, is to make sure that the island is malaria-free. And what we intend to do is we hope that at the end of 2025, we should be at pre-elimination. We want to make sure that 80% of the population has access to malaria prevention, diagnosis, and treatment. As I speak, we have provided commodities on the island. All tests are free, antigen-based RDTs. For pregnant women and children under 5, treatment is free. And we hope that this will also have an impact. So we have a clear roadmap. I'm not going to, again, take too much of our time, but we definitely have an impact model. For us as a company, it's about the end result. And we are fairly confident, come 2025, we should be presenting what will be hopefully impressive figures. Perhaps even maybe we may then be talking about an island that is already at pre-elimination on our way to elimination. So I'll stop here and I'll give time to the next two speakers who will give you the more what I will call technical presentations around what we did around ACSM, and also for me what was really exciting, the operational management committee we created. And I'll just quickly add here, as soon as we started, the pandemic started. And what happened was that became an excellent tool that we used in impacting on our COVID interventions for the community. So clearly it's something which is not just about malaria, but we know it's going forward. It's going to be a very impactful way we can get health to everybody on the island. Thank you very much.
Hi everyone, my name is Edima, and I'm a doctorate student at Boston University. I was formerly working on the Bonny Malaria Elimination project before I started my studies. Sorry. So I want to thank my team for giving me this opportunity to present work that we did while I was back in Nigeria. So thank you. So my presentation is on the use of behavioral economics in health facilities and communities to drive ownership. So we have put in a lot of effort with assessment to understand the community, understand the health system, the people and processes. And a big part of what we wanted to find out was around behavior. So behavior of providers and clients and how this affected the work that they were doing, and then for the clients, their uptake of malaria services. So we adapted the NMEP, the Nigeria Malaria Elimination Program's behavioral economics tools and prototypes, and we adapted some of them to our context. So we followed this process flow. So the first was the problem definition and behavioral diagnosis, where we were able to explore to understand those gaps around behavior for providers and clients. And then we did an intervention design based on insights that we got from the behavioral diagnosis. And then we implemented for a 1-year period. And we conducted an evaluation to see how well we had done within the 1 year. And then after the evaluation, we were able to use the findings to tweak certain areas of the work to continue our implementation. Okay, so the behavioral diagnosis findings. One of the things we found from doing provider interviews and interviews with the clients and some observations at the facilities, we found out that the providers have to consult with large number of clients, and there's usually like a lot of pressure, at the facility. And because of these, you could find the provider, not adhering to diagnosis and treatment guidelines. And another reason why some providers would not adhere to the national guidelines is they believe that they are strong clinical experts, and sometimes after doing their initial evaluation, then send a client who they are confident might be having malaria, they'll send the client to the lab for further investigation. And the client comes back with a negative result. There is usually that back and forth to convince themselves that the malaria test is correct. Meanwhile, their initial evaluation showed that the symptoms were speaking towards, this client's likely having malaria. So because of that, they might want to go with their own expert judgment instead of following the, test results. At other times, clients put them under a lot of pressure. They are so confident that, these are the kind of signs and symptoms I have when I have malaria. And then the provider is telling them, sorry, your test result says negative. But with the whole back and forth and strong opinions of clients, they might get to treat that client even when the client, is testing negative but wants to be treated by all means. So all of those findings were key things that we saw around, provider behavior, and we thought we could apply behavioral economics, concepts to work on the behavior of the clients and the providers to help us, improve uptake and then improve the quality of services that the providers would be, giving to the clients. Okay, so for the intervention design, we looked at different components. We looked at what we could do at the facility level, at the community level, at the LG and state level, and then some other cross-cutting issues. So for the facility level, as I mentioned earlier, we adapted some of the prototypes from the national program. We also conducted the behavioral diagnosis, and then we did facility level training of providers, doctors, nurses, pharmacists, lab people, and others at the facility. We also mapped different service points where we thought we could modify certain processes and flows to make the work better. At the community level, we also did lots of training of the local government and the ward level personnel. And then we also engaged community volunteers who are residents of the different communities, and we trained them on demand creation. And currently they have been working at the community to meet members, households, to talk to them about malaria risks and how to prevent malaria, how to access malaria diagnosis and treatment services at the various facilities. So at the local government level and the state level, we have trained them. So we did some training of trainers. So we have local trainers that can handle different parts of trainings for our different thematic areas, especially the behavioral economics aspect. So we also have involved them in the whole process of the design of the project and also design of the tools that would use to measure the performance of the project. Then for the cross-cutting issues, we have been able to embed supportive supervisory mechanisms, things around data quality assessment. We had already had a data quality assessment system in place, but we had some areas in the behavioral economics initiative that we embedded into our existing DQA process. And then we did the implementation planning and then the reporting components. So these are some of the tools. These are some of the tools. So we have different clusters for the tools. The first is testing before consultation. So testing before consultation is, let me just explain the concept. So we expect that as a client comes into the facility and meets the nurse for taking vitals, and then while waiting to see maybe a doctor or a clinician, the person would do an RDT test if he or she came in with a fever or fever history. So that way, when they actually go into the consultation room to meet the clinician, they already have their test result as negative or positive. That way, the clinician would not have to struggle with the whole process of guessing whether this person had a symptom of malaria or not, or if this person is positive or negative. If it's positive, they go ahead to, prescribe drugs for pickup, and then if it's negative, they can explore other reasons why this person might be sick. We also have the consultation packet. So the consultation packet had different tools that would guide the clinician to diagnose the patient properly. So those tools are like pointers to guide them on different questions they could ask to properly investigate a client. We also have the data and accountability tools. So those are for performance management within the facility to track how well they are adhering to, the national guidelines on diagnosis and treatment. We also have the provider communications and the client communication tools that just pass different messages around, encouraging them to do proper diagnosis or to access diagnosis services, treatment, and then other important details around malaria services. So these are how some of the tools look like. It's not all of them, it's just a snippet. So for the implementation, I'd mentioned some of the things we've done already, but we've done service delivery at the facilities. So we had, as Dr. Okuns had mentioned, we had provided them with, drugs and then test kits and then other forms of support. And they also use the behavioral economics tools to guide them in the service delivery. For demand creation at the community, I had mentioned that the community volunteers were providing community services to the residents of the community around malaria, awareness on malaria prevention, treatment, and how to access, care for malaria. Then we continued to train and retrain different service providers, both at the facility and community level, wherever we found a gap. So if we found a gap in case management, would repackage our training and strengthen those areas where we thought there was a problem. And we also conducted supportive supervision and data quality assessment exercises periodically. But something we did routinely was tracking the data. So we did weekly data and commodity tracking at the facilities. And this helped us to always quickly identify wherever there were issues and then quickly fix those issues. We also did, or we are still doing, facility monthly performance management meetings where the head of the facility would, come together with unit leads and then unit members to discuss issues around malaria. So in recent times, they've tried to incorporate other aspects of, the facility to discuss, around it every month. So these are what the results look like. During our evaluation, our one-year evaluation, we had for malaria diagnosis, we wanted to see how well they are able to adhere with the national guidelines. So you can see that as at April, they were at 25%. So that is the proportion of persons who presented at the health facility with fever or fever history that were able to receive a malaria diagnostic test. So it was really bad at 25%. And then we also had issues around data quality and others where they couldn't capture properly. They could capture fever cases, but not cases where there was a fever history. So you would see where you have like 121%, 134%. But from the 4th month, we were able to stabilize, and in all the facilities, they are able to test every patient that comes with fever or history of fever. For the treatment, it started at 81%. So that's saying the proportion of persons who tested positive for malaria and were able to be treated with the appropriate malaria drugs according to the national guidelines. So there have been improvements from 81%, and now we are somewhere at 98%. And we have had slips here and there, but with the constant reinforcement and retraining, we've been able to significantly improve from where we started. This is for malaria in pregnancy. So how well are they adhering to the national guidelines on malaria in pregnancy? And this is calculated as the proportion of pregnant women who received, eligible pregnant women who received intermittent preventive treatment for malaria. And we started at 80%, and just going through it, it's much improved now since the beginning of this year. So we've somehow gotten to a point of stability with that. So this is the retraining for the community volunteers, and some of them were actually demonstrating how they've been communicating at the community level. And these are some of them doing brainstorming sessions and the areas they needed to improve with regards to their demand creation activities. And that graph is showing their test results. So we usually conduct like knowledge check quizzes periodically. And the first, the lighter blue is showing their knowledge check as at last year. I think that's September last year. And then more recently in July, they also did another test. And you can see how significantly they have improved on their knowledge because of practice. So, consistency in the work that they are doing and in practicing has really helped them to improve their knowledge and also pass same to the community level. So we've also engaged a lot with the local government, and this is the local government health department team who were part of the implementation evaluation after 1 year. And where you have this is the medical officer for health for the local government area, and then that's the head of a primary healthcare facility, and that's me. So this lady said she's very confident that even in her absence, none of her staff would, would give drugs without, sorry, I don't think I mixed that up. So none of her staff would, give drugs to any person without testing first and ensuring the person is positive. So that's like a good testimonial from a primary healthcare facility at, Bonny Island. So thank you.
Good evening, everyone. My name is Anastasia Isodje, and I'll be talking to us about what we have done to reach every household using our community health system and local structures. So we really like to talk about a group we refer to as the Operational Management Committee, and you must have heard that mentioned already a number of times. So this presentation will touch a bit more on that. Now, you and I will agree that individuals are influenced by their community. And that's part of the reason why if you go to a certain place, you just try to find out what's the norm here, and then you kind of try to fit in. So in these communities, you will understand that that's the same pattern. And that makes community health system a serious area to pay attention to. So for us here, we have looked at several models, but we found one that we think works for us. And that was one done by the USAID in their healthcare improvement project. And so we have taken that model and we have modified it to suit our local context. Now, this is just to tell us about the elements of a community health system. So basically, if you're talking about this kind of system, you're looking at community groups, and those groups are, you have groups like the women's group, you have the trade union, you have the informal health sector, you can't leave them out. You also have the traditional structure, which we observed in most of our search had been a group that was being neglected when you make reference to community groups. And then we have the indigenous groups and non-indigenous groups in those areas. Now, all these groups, we pooled their leadership, and those are the persons that make up the Operational Management Committee, which you will see is the second element that we need to pay attention to in community health system. So you have that committee comprising of the leadership from these groups, and they are able to support with decision-making regarding health for their community. And then we have the third element, which is the formal health sector. Now, to add that, the formal health sector also has membership slots in the Operational Management Committee. That way, we're able to have all the different representation of the community interfacing at the level of that community, that committee, sorry. So that's the essence of these elements. For us to be able to get to the point we're at with regards to strengthening Bonny Island community health system, we had to take some of the information we gathered from the ACSM mapping, that's the Advocacy, Communication and Social Mobilization mapping and profiling, that was done earlier during the baseline phase of the project. So during that assessment, we were able to get a lot of information on things like community governance, and that was able to tell us how strong and how rich and how influential their traditional leadership happened, the kind of influence they have on the people. So we're able to get that information. We're able to look at their naturally existing communication channels because we didn't want to duplicate our efforts by building a parallel structure. And we also looked at their healthcare seeking behavior. We talked around malaria as a problem, severity, causes. We needed to have a better understanding of their perception. And we did that. And all of that informed what we put together for the health strengthening package for the community, as well as the operational management committee. Then we also got recommendation from them on what they would expect from us. I'll give you an example. At the community level, this is before we set up the committee. At the community level, we had about 71 focus group discussions, and in at least 85% of them, they told us they wanted to be able to pay for their medication. They didn't want free medication because they want to be able to come to the facility and hold those providing care accountable. So they insisted on paying. So that's an example of what this kind of engagement was able to get for us. So when we were setting up, we already knew from the onset that we will not be providing free medication except for pregnant women and children under 5. Now, this is just to show typically what we expect the community health system to look like. And so for us here, we added this because we recognize the power of the traditional structure in Bonny Island. And in Bonny Island, they refer to their houses as opuwari. So we have a number of houses that, for lack of a better word, report to the king of the kingdom. Those houses have chiefs, and their chiefs report to the king of the kingdom. They refer to them as opuwari, and it's a communication hub. It's a place where information flows freely and quickly. And so we quickly took hold of that and included them in our community health system. And so in the course of selecting the members of the Operational Management Committee, which you will see here in the middle, we ensured that the kingdom played an active role. So they had membership, they had members they put in, and they were also the ones who gave us one of their chiefs, who is the chief in charge of health, and so he's the chairman of that committee. And then we also have the local government represented. The local government's current chairman is the vice chairman of that committee, and then we have a youth leader as the secretary. Now, this gives us very strong persons in our committee, and they're able to influence the community when something needs to happen with regards to not just malaria, but health as well. We also had the religious groups represented. We had the informal healthcare sector, like I said, represented. We had the women's group represented, the indigenous groups. And we also had the medical officer of health as a member of that committee. So there were some decisions we were able to take in that committee, and each person will take on their role and go back to their various constituents. Now, to set up that operational management committee and agree on our strategy, we had a stakeholders consensus building meeting. And at this meeting, we ensured representation from all the different key stakeholder groups. During that meeting, we engaged and we presented our baseline findings so that everyone is on the same page with regards to what is happening on the island. We also proposed the strategy for malaria elimination on the island. In addition, something interesting we did was we had quickly teased out possible project risks. And during that meeting, we allowed each stakeholder group identify the risk that they were likely going to be the ones contributing to, and they were also able in that meeting to tell us, this is what we'll do about it. And so we did that. So the project mitigation actually did come from them. It didn't come from us. We drafted a communique there. We constituted the Operational Management Committee in terms of the offices or the persons that will be represented in that committee. And then we drafted a terms of reference for that committee to guide their activities and efforts. After we had done that, we invited them for a meeting, and then we brought in consultants. We ran a series of trainings. We needed to empower them with certain skills, particularly with regards to program and project management. And then we divided them into 3 functional groups based on the current needs on the island. Now, those 3 functional groups, we have one group takes care of supervisory and oversight role. We have another group that is responsible for demand creation, and then we have a third group that is responsible for commodity security. Those were the core things we were very quick to identify as areas that they could function in. Now, this is just highlighting some of the activities that the Operational Management Committee got involved in, and just to highlight some of what we have been able to achieve so far. They were able to take a decision on commodity pricing. I can tell you that we had excellent attendance up to date. We always have at least 80% of those in the committee present in every meeting. We developed plans, action plans for us to work with. We developed plans to work with, based on what we had already projected as a strategy for the project. So the Operational Management Committee paid attention to that as well. They championed community sensitization activities. We already talked about engaging the community through community volunteers. These volunteers were actually nominated by the Operational Management Committee as well. And this is just to say that currently, the only thing we can say we have not really had the Operational Management Committee do is lead in the interventions or activities, but we always ensure that they played an active role in decision-making and in delivery. So we always made sure we empowered them enough to be able to do what needed to happen. Now, this is an example of one of our, we think this is one of the success stories we can talk about with regards to working with the community. During the net distribution campaign, we had very good coverage because the Operational Management Committee used their own local structures and naturally existing channels to disseminate information. Something I would like to say here is that the Opuwari, if you ask them, they will tell you if something happens in Bonny Island today, and you need that information to get to the king, it will happen in one day. I don't think there's a better system that will give you that speed in disseminating information other than, maybe our technology. But to think that without technology, they've been doing this is commendable. So we are leveraging on that system, and that did help us even during the net distribution campaign, because we could get feedback in real time from different parts of the community because they had such a good structure. And our coverage was really high, and net uptake redemption was really high as well. This is just one of the communities. I like to show what the kind of place we're referring to when we say we had to reach. We're talking about reaching every household. So if you look at this, vehicles could not get to this place, so we had to work on. And like my colleague said earlier, we have a lot of swampy area here. So sometimes you have to get on wooden platforms to just walk across and be able to reach these people, and we were able to do that for the net distribution. However, one of the things we quickly recognized was that post-net distribution, we had very good redemption, but we had very low percentage of persons started using the nets immediately. And I can tell you some of their reasons. They said things like, oh, we've not seen a net in a while. We want to hold this one first and wait. And when we get the next one, then we will start using this one. We had to explain to them that these nets were designed with insecticides that are sensitive to the vectors that we currently have on the island. So if you're using an old net, and based on the insecticide resistance monitoring survey we had done, you're using a net that doesn't have something that will work, then it's not going to work. However, we needed to go back to find out whether we had seen some improvement. And we did that again through the Operational Management Committee. So they were the ones between the end of March and first 3-4 weeks in April, between the end of March and 4 weeks after that, they were the ones who went into the community, worked with the community volunteers, and we now had an opportunity to go into the community and pick up data again. There was an outbreak response being organized by UNICEF, and so we just attached health educators to those groups, and they went around, they got the data, and they also educated the people some more on how to use their nets, how to care for it. And you can see from the bars here, the blue bars you're seeing are just bars to show you those who slept under the net the previous night. So you have 84%, and these are all the different wards. So you have 84% in Ward 1, 91 in Ward 2, and the lowest here for us was 66. So we had that kind of utilization, which was really good progress. This is another remarkable thing the Operational Management Committee also did. So beyond what we have seen now, they are looking at how do we link the community to the facility and ensure that there's good uptake of service and ensure that every pregnant woman in the community is captured, whether they are going to the formal or the informal sector. We have to look for a way to link them up. So we worked with them, and they were able to come up with what you can see on the screen right now. And it's still work in progress because we're still trying to roll it out and implement what has been proposed by the Operational Management Committee. But this is just to show that because we are working with them and empowering them, they are able to do so much more. And that is a model we think is really good. For us, this is what success will look like. A lot of times we have our healthcare workers and they are running alone, solo to the households. But what we're trying to do right now is have something better coordinated, where there's integration. We're not dealing with vertical programming anymore. So we have a bit more integration, and then we're having different services being provided through one healthcare worker. And the Operational Management Committee has been able to help us do that to a very large extent, because although we are a Bonny malaria elimination project, we recognize that when someone comes to a facility, they don't say, I'm looking for who will take care of malaria. What they want to do is they want to see a doctor. So you really have to empower whoever the healthcare worker is to be able to provide those various services and at the same time reach the different households. This is something else we're looking forward to, which is what we call the Opuwari surveillance. I already tried to explain that if something happens now and the king needs to hear about it, it gets to him in less than 24 hours. This was also something that the Operational Management Committee put together, and we're looking forward to implementing it, and someday hopefully we'll come back and present and tell you what this was able to do for us. So I've come to the end, and but before I leave, I'd like to say thank you to all those who have supported the project and who have been very much involved in helping us. Remember, we're an oil and gas company, So what we really know is oil and gas. But we've had partners come in and they have really helped us. So, I mean, I know you can see what's on the screen, but we have the National Malaria Elimination Program, who give steer to everything in the country. They've really helped us. The PMI, the Rivers State Ministry of Health. Remember, Bonny Island is in Rivers State. We also have partners from PMI who have been very supportive as well. And I would say we cannot live without recognizing the kingdom where we work, because we've had very peaceful community, very supportive. Some of what we are presenting here is easy to present just because of the kind of community we work in, not because it is like that everywhere, I must tell you. And then we want to thank a group that is not really part of Nigeria, but they've also supported us technically, which is the Zanzibar Ministry of Health. And of course, the last but not the least, our community health workers. We couldn't have done a tenth of what we are doing without them. So we just want to recognize them. Thank you all.
Last slide. Which one is the last slide?
Okay. Let's give them a round of applause once again. Thank you very much. So we'll now go to questions, comments from the floor. Please, if you have something to say, just walk up to the podium. Sure, please.
Hello and thank you. I'm Chris Warren.
Is that too low? Maybe you need...
I'll just do this. Okay. I'm Chris Warren. I'm from PMI. I really appreciate the opportunity to learn about this project. You've described a very interesting community and a very interesting ecosystem, the concept of the island. And I'm thinking as you're presenting that you also have some very interesting members embedded in the community, a community of experts in their field, which would be liquid natural gas. But we have people who are familiar with security and logistics and communications and monitoring and evaluating and production planning and scheduling and things like that. And I'm just wondering if those members of the community, those experts, if they have an opportunity to contribute to the planning for things like the execution of the net campaign or any of the other activities, because they are a potential resource that can provide their level of expertise and make a better contribution to the community that they're living in. Thank you.
Thank you. Yeah, I think we'll just take the answer. Huh? Yeah, take them as they come, brother. Yeah, thank you. Okay, okay, you can use this.
All right. So yes, indeed. For most of our projects, so like Anna said, we did have partners, but as an oil and gas company, there's a lot of expertise, within the company. Here, for example, is community development and sustainability, medical, logistics, security, all involved. So even badging the nets in, because they have to be badged in, stored somewhere, distributed. We have the entire mechanism of the company at our disposal, and we use them, and we continue to use them. Where we don't have in-house expertise, then we go out to the technical experts, for example, USAID, VectorLink, etc. But all working with them. I mean, we're an island. Even to get into the island, it's a lot of logistics. And especially when we have those who need special security to come in, we have to handle all that. So absolutely, we've used everything at our resources to get things done. Thank you, sir.
Thank you. Sam Aula is my name. I work for the CDC. This is quite brilliant, and I know it's a project that has a lot of prospects. I'm quite interested that you quickly identify the area of hot transmission hotspots. My question is, what are the intervention package in those areas to bring down the transmission? That is one. Two, if I got you right, your baseline prevalence is kind of 17%. right? And moving from 17% to pre-elimination within the framework of 3 years. I don't want to call it a tall order, but the question is, what other innovation do you want to bring in to make sure that that is achieved? Thanks.
All right, thank you. Thanks for that question. So just to say quickly that the prevalence from our own survey, which we did, was 5.4 actually, 5.4%, but it had a range. And we happen to have a community as high as 32%. So that's the community we quickly recognized as a hotspot, and they needed, like you just rightly pointed out, a different intervention package. So currently, because one of the things we're trying to do is work with an integrated package, we already have, as a country, a design that encourages that. So we just leverage on that. And so we leverage on things like outreaches, and we also track who is coming from where in the facility, so that we're able to tell if there's a build-up again in that community, then we know we have to do something targeted. However, when we just started the project, we actually did have a targeted activity there, and we worked with, we work with the community volunteers and the community leadership as well. So they give us information on how many more cases of fever, especially children under 5, that they're having. Otherwise, we're working with interventions that are based on the National Malaria Strategy. Thank you.
Thank you. My name is Arciolanda. I'm from PMI Angola. Actually, Angola is also an oil-producing country. In fact, we come behind Nigeria in the whole continent. So this is a module that I think myself would take it to the NMCP and the country and try to replicate. What I'm interested to know is, I don't know if I missed it, but what's your beneficiary size, the population size that you benefited? I mean, in general, in the island, and then your target population that you benefited, particularly, as you mentioned, children under 5, pregnant women. Also, the work of the community health workers, as you commented, were those community health workers paid? Did they receive any kind of incentive? How they were maintained? And I see that the line of the life of your project is until 2025. So how are you seeing training these community health workers, and if they are receiving some sort of benefits, and if the SBC materials were also translated into the local language, or was that all in English? Did it make a part in the community uptake of the services? And also, I don't know if I missed the last, what's the size of the project? I mean, in investments, in dollars, how much? Just to have an idea. Thank you.
Yeah, you can use the other, yeah.
With regards to the size, so best bet about 250,000 roughly to 300,000, and that's the target. So the entire island was the target. Wards 1 to 6. There are some other wards that are almost impossible to reach. Maybe we hope to scale up to those places later. And therefore, for example, the surveys we did and everything we did was targeted at reaching every household. With regard to the community healthcare workers, so one of the things we from the very beginning, we decided sustainability was very important for us. And what we did was to then leverage on the existing infrastructure. So Nigeria has a very good primary health care system. That's the truth. So what we were doing was empowering those people to do their work. But typically when we train, we did pay per diem for coming around and something, but we don't pay any special amount of money for them to do the work. It's so important. We believe that The moment you do that, and for any reason we stop, then everything will stop. Everything we did around getting the OMC was ownership and basically getting them to do their work, which we're quite pleased at the enthusiasm that they have shown. With regards to the cost of the project, I would respond the way my boss responded when this question was brought up at the MOU we had with the USAID. Nigeria NLNG will commit whatever it takes to get the project done. The line to 2025 is not when we... I'll tell you, when we started, we were thinking of something that would be 1 to 3 years at most. As we got into the project, we understood that elimination was not something you do, in a given time. And immediately I went to management and said, look, forget that 1 to 3 years project. We are here for quite some time. And we learned again when we went to Zanzibar that getting to pre-elimination, then you have a new problem. Now you have created young people who are now non-immunes, and therefore malaria becomes very deadly. And we've made that clear to the business. We're here for whatever it takes. I hope that kind of answers.
And the last question that they have not, he didn't talk to is the question of language, whether we translated the materials into any special language. The good thing we have about Bonny Island is that interactions with, could I say, Europeans started way back in the 15th centuries. So they have had the opportunity and the privilege to understand English language to a large extent. So a lot of the community communications and engagements happened in English. And then when it gets to the far and distant places, they go back to using the local language, which is called Ibani language. But materials have not been translated into Ibani language yet, but the community health workers are able to use the training they have to be able to communicate with them directly. So that is actually working, and we hope to continue to do that as we progress towards the pre-elimination state. Thank you.
Okay, sorry, 1 minute, please. So I wanted to find out, how are you tracking your impact indicators? Because we said it's supposed to end, you're supposed to meet pre-elimination by 2025. So at baseline, you were 5.2%. So how are you tracking those indicators, and are you planning to, not how and then that's the frequency, and what methodology are you using? And also, do you plan to do like a midterm review to see how far you have come, and how you intend to move ahead with achieving your targets?
All right, yes, thank you. So yes, we plan on having midterm review. Just to remind us that because of the disruption from COVID, we've basically been able to implement for just 1 year. So we're working with the impact model we had projected earlier, which is looking at all indicators from input to our activities to outputs, our outcome, and also impact. So yes, we hope to have a midterm review where we would look at more of outcome indicators at that stage. And these will be indicators that also align with what the National Malaria Elimination Program is doing. That's also part of the reason why we are very particular about partnership, because we recognize that irrespective of how much we can bring to the table, it is still not our core area of work. So we will be working with you, Dr. Perpetual, and your team in handling that, because definitely we need the external validation. It's not something we just want to do on our own. So that is what is going to happen. And then, of course, at 2025, we're going to be looking at an end of project evaluation where we will be looking at impact indicators in the population as well. Thank you.
I have a microphone. Okay. Okay.
For my seniority over you. Thank you, ladies and gentlemen. Your presenters, very interesting. I'm impressed with what you have done so far. I have in my hand here the Bonny Malaria Elimination Project. Do I take it that you came here to tell us how far you've gone with the project? Or do you have a time limit when you're supposed to conclude this project? The next question is, Bonny is not too far away from Port Harcourt and the city. And it's an area where people go fishing practically every day. How do you plan to control the movement of the populace going to Bonny to fish and coming back and be able to eliminate malaria? Thank you.
Okay, thank you, Prof. I'll take the second part of your question. Bonny is 40 kilometers from Port Harcourt as the bird flies, or as the crow flies. And a lot of the movement between Port Harcourt and Bonny are mainly by the indigenous people also. They fish and they replenish their stock by traveling to Port Harcourt for supplies. Sometimes they spend a day, sometimes they don't even spend a whole day, so they come back to Bonny. A lot of the fishing activities are also done by the residents, because fishing is their pre-occupation, their main occupation. Of course, you know, an island community will always be fishermen. And all of what you have heard today, including the engagements and the community health workers and all, the fishermen are involved. In fact, they have a very strong and vibrant fisher folk association, which we also engage on a regular basis, helping them to understand that fishing is also a hazardous occupation. Because when you sail into the ocean, if you don't have your compass, with a small boat, you might get lost because you do not see the nearest land from where you may be at. So we also help, as part of the other programs we do beyond malaria, to supply them with nets, fishing nets, supply them with life vests, supply them with compasses and headlamps for them to be able to navigate their way into the ocean and back as fishermen. So there are no real external people coming into Bonny to fish. If they do, they will be in places where they call the fishing settlements. And we also have access to the fishing settlements. You saw some of the photographs. I will allow Dr. Okuns to take the first part of your question, Prof. Thank you.
All right, I'll just add a bit to that. So one of the things immediately we are thinking about is imported malaria for a very simple reason. The biggest CSR we have right now is what we call the Bodo-Bonny Road. That's the Bodo-Bonny Road. It's a bridge, 32 kilometers, that will link Bonny Island to the mainland towards Port Harcourt. So as we are doing our M&E, setting it up, we are also very aware of the fact that we'll have to have what we'll be calling more like rapid response teams that will be able to identify whenever we pick up a case and then do a quick surveillance in the area. So that's part of the long-term plan for this project, which brings me to the first question. So already, like I said, in truth, when management said, I remember they said, we give you 3 years to eliminate malaria. And we're like, okay, let's see what we can do in 3 years. But as you can see from our plan, that's an initial 5-year plan. It's an initial 5-year project. As a company, because of the way we are structured, the way we budget, we must have defined times for any activity we have. We cannot have an open-ended project, but it's clear to management that this may take more than 5 years. And besides, even when we do attain pre-elimination, we may still need to be involved. But I will say something here. One of the things we've tried to do from the onset is not to introduce activities that are not already a part of what is in the National Malaria Elimination Program. Even when we do our annual operational plans, we don't go and say, we're going to fund this, we're going to fund this. We ask them, what can you do in all the thematic areas so that it's owned and to some extent funded by them. Yes, we are putting money into things like the entomological studies. Our partners are helping us with nets and all. And those are the kind of things we hope that we may need to be doing. But with regards to running the program, and more importantly, maintaining pre-elimination, perhaps moving to elimination, we are hoping that it will be in such a way that the NMEP structure will be able to take us through. But whenever we are needed to support, we'll be there to support. And we know we have partners who will also do that with us. So it says 5 years, but it'll be more than 5 years. We know that. Yeah.
Yeah. God bless PMI Côte d'Ivoire. Congratulations for this program and also great presentation. I would like to learn from you because we have a key challenge in terms of partnership with the private sector. You're supposed to work with a private company. So I would like to go beyond your result, your success. What have you done to convince your leadership to engage you in this kind of program? Which advocacy have you done? And also, in terms of partnership, maybe you have, as company, your own fund to support this program. Do you have a partnership with our partners such as Breakthrough Action, PMI, they fund you, just to understand how this joint or this kind of partnership help you to be more successful? Thank you.
Okay, thank you. So the vision of the company is making a better Nigeria. This project is not amongst the biggest projects we do in the CSR space. So let me admit that. So one of the things we deliberately do every year and all the time is, as a company, to see how we can influence whatever systems, do whatever it takes to just make the country better. So I'll admit it was not difficult getting management to buy into this, all right? The biggest thing we hope will happen is that we will show other private companies what is possible. And that's why we are so focused on the impact of this project. Because we know that once we can demonstrate that a private company in partnership with public and the people can achieve, then hopefully, we are not the only oil and gas in the country. Hopefully, others will begin to see a model that they can emulate, not just in Nigeria, but also in many other areas where the peculiar problems we have, where it's really very difficult for government to fund completely, will happen. So the truth is that it wasn't difficult because that is in the DNA of the company. And we hope that this story, you can take it back and say, hey, there is nothing so wrong in the private sector contributing. And not just contributing in saying, oh, we've put in X amount of money into the project. The question is, what is coming out of it? And many companies like ours, like was said initially, have the expertise within to help with such things, with tracking, with logistics, with M&E. It's all embedded, and this can also be shared with the government structures to just make it better. But I'll also advise, as we are doing, do not create parallel systems. It never goes well. What we've tried to do, and what I hope we are doing well, is staying within the National Malaria Elimination Program and just strengthening it. I hope that answers. Yeah. Thank you.
Thank you very much. So much have been talked about with economics and all that. Let me speak like a scientist. And so we've been leveraging on a lot of things. So I want to ask about some other things that we could also leverage on. When you tested the people before they are treated, some were positive, some were negative. First question, the ones that were negative, I think for sometimes ethical considerations, did you have any provision to further see what was wrong with them? Because, or did you just send them home? You don't have malaria, you're not part of this. Second question, the ones that were positive and were treated, did you follow up on their treatment? Did you further retest them after treatment to monitor treatment outcomes and probably see if there is actually resistance? Because I know that anti-malaria resistance is one of the issues that is making waves, but we don't have a tracking system for that. But if you monitor treatment outcomes, maybe that could also provide another data subset that we can all also leverage on. Thank you.
Yeah. Okay, all right, thank you for that question. So I will say that, yes, we found some negatives, and so that's part of the reason why we encourage that the free testing is done in the facilities, so that way, because they have accessed the facility, there can be further testing done. However, when we have outreaches and we test and they are negative, we refer them to the health facility and we give them a referral card. We track it to make sure that they actually do go to the facility and access care. In fact, we had a case of these twin children who actually came in and they were so malnourished that at the age of 11 months, they could not sit. They couldn't sit up, you know. So that was that was where we saw our projects, our different projects come into play, you know, as in terms of synergy. Because when we found that as a malaria project, we went to the insurance team and we were able to get the children registered under the insurance program, and that way the hospital was able to provide care for them. So when we have negative patients, we do take it further with some more testing, depending on the level of the healthcare service they've accessed. If it means going to the secondary health facility, yes, they will go there. You also asked about what do we do after we've tested, you've treated, do they come back to test again? We don't get them to come back to test again for now, but I'm glad you mentioned this because that's one of the studies we have already noted. One of the things we have noted as part of our research agenda that we would like to do beginning of next year. But what we do for now is when you test and you go away with your medication, we have the ward focal person follow up to make sure that they actually did complete their treatment. And if the child or the person is still having a fever, we ask them to come back to the hospital. So all that education, patient education happens when they come. And yes, like I said, the ward focals follow up, especially the children under 5 and pregnant women. Does that help? Thank you. Yeah.
I have the mic. Right here. Right here.
Okay, you want to ask a question?
Yes. Okay, so, well, comments and maybe 1 or 2 questions. So thank you very much. I know we're in this together. A great job, I would say. But I also wanted to, as part of comment, to say that, yes, your 2025 might be possible, you know, because from the program, We're also working very hard to see that a lot of more tools are put on the table, in terms of prevention, chemo prevention for under 5s. So just to say that very soon, tools like PMC, will be deployed to that part of the country. So you should be very optimistic for your 2025. But I just also wanted to say that, or to ask what your experience is with private sector healthcare providers, like the private hospitals, the community pharmacists, so what is it like for you? What are you doing? We need to hear a little bit of that. And then also, just to add, what's your antenatal care coverage or even rate like, versus IPTP 3+? So we want to be, hearing such, because those are the things that are kind of evolving for WHO in terms of WHO recommendations, and we want to see that, such parameters like IPTP 3+, what the uptake is in terms of that. Thank you.
All right, thank you for your question. I think I'll start from the last one you mentioned, which is IPTP. And antenatal uptake. So I will admit that IPTP 3 particularly has been low, and I think that is a problem that we're really concerned about, just like you noted. Something we're doing, however, on the island, which we observed already was happening in some facilities, they work with the traditional birth attendants. So what they do is the traditional birth attendants bring clients to the facility. And so we decided to also support that. So we have, in the facilities, they have 2 records. They have the booked and they have the unbooked. So what happens is they come, especially the unbooked, they must always, so part of what we are supporting is ensuring it is dots. It is not you take your medicine and go away. It has to be dots. And then we make sure we also track that register with them to ensure that they are following the regimen. Remember, it's happening in the facility, but these are women who are not booked. Now, that is helping us to reach more pregnant women. And in some cases, some of them actually eventually decide to register in the facility and give birth there. But it's been able to help us reach more. We also want to introduce routine distribution of nets through that channel as well, so that those women who go to the TBAs can actually get nets. So those kind of partnership are helping the TBAs work with us closely in ensuring that their clients are still coming. Then for the patent medicine vendors particularly, this is one of the areas that I believe the Operational Management Committee is really helping with. Because of the traditional structure that they have, the community works in a way that you can't do anything just because you want to do it. So what do I mean by that? We may not have very good regulatory structure for these service providers in the community, but once you educate and empower the community enough, they actually take that decision and say, you cannot do this or you can do this. I'll give you an example using the nets. Currently, we are still looking out to be sure that our nets are not with patent medicine vendors right now being sold, maybe because during the distribution they were able to get some. Until today, we've still not been able to have a report like that. Now, that is not to say there are other things that we don't get to hear about. We've gotten reports about how maybe a pregnant woman went to the facility and she was not given SP for whatever reason. We investigate it. So we do have those kind of reports, but this is really something the OMC has been able to help us with. They bring that feedback. With regards to the hospitals, private hospitals proper, the same problem everywhere is still prevalent, even in Bonny Island. So we are really trying to get the Ministry of Health to support us in that area, because at the end of the day, they are the ones who regulate those institutions. Yeah, thank you.
So take one last question.
Yeah, I'm Kayode Ojo.
Great job and great work with the plan, and it's really commendable. But my question is coming from the science aspect of malaria biology. One of the big issues with malaria eradication program is that a lot of patients do not show parastemia, but they carry the disease. And we also know that even in a case of treatment, you are still sexual stages for about 4 weeks. So my question is, how do you factor that into your program?
Okay, let me quickly respond to that. Thank you for your question. And if you remember, we tried to start by saying that we are working in line with the National Malaria Elimination Program guidelines. So we're not going outside of that. A lot of what you have suggested now, yes, we know that the WHO Global Technical Strategy recognizes certain interventions that we have not yet adopted as a country. So for this project, thankfully, working with the national body, if we get to a stage where we need to introduce the kind of medication and testing you are talking about, then we will be able to get that guideline and clearance from the national body. I hope that helps. Yeah, thank you.
Thank you very much. I just want to ask one last question. So your data is how closely are you working with the Rivers State Ministry of Health? Is all the data from Bonny Island being reported onto the District Health Information System because your routine data, and are you also providing airlines for under 5s and pregnant women as at the immunization clinics and ANC clinics?
Okay, so our data, yes, it feeds into the DHIS. So even when we go to get our project data, we work with the M&E officer for the local government area. When we have our facility performance meetings, we ensure that the medical officer for health is present. We support the data validation meeting for the local government as well, just to ensure that all that is getting back into the national system. For LLI at immunization and antenatal clinics, we started that this November. Yes, thank you.
Thank you very much. I think let's give them another round of applause. There's some refreshment at the back, so on your way out, you can pick up something. Thank you all for your participation. Thank you. Thank you.